For everyone on the line today, I'd like to welcome you and say thank you for joining us today for this webinar. I am Trish Hutcherson, Orion Health Corp's Marketing Director, and I will be with you today throughout the session as your moderator. On behalf of everyone at Orion, we hope you enjoy today's presentation. And before we get started, I would like to run through a few housekeeping items. We will be muting the phone lines today for the duration of the session. However, if at any time throughout the presentation you have a question, please feel free to enter them into the GoToMeeting dashboard on your screen. Technical and logistical questions will be answered in real time. However, questions related to the content will be answered at the conclusion of the presentation. All of today's participants will receive a copy of today's presentation with an audio playback option to listen at your convenience. And with that, I'd like to introduce today's speaker, Karna Morrow. Karna is a member of the consulting team at Coding Strategies located in Powder Springs, Georgia. Karna's expertise includes billing and collections, coding and compliance, revenue enhancement, and process improvement within medical billing firms, community and academic hospitals, as well as private practices. Prior to joining CSI, she held the position of Director of Coding for 2 national radiology pathology billing companies, as well as a regional medical director in Northwest Missouri. As the coding supervisor for Stanford Medical School's faculty practice program, she was able to establish office and departmental procedures and compliance that recouped millions of dollars in inappropriately reimbursed or denied medical claims. Process improvement recommendations reduced charge lag time by 20%. Karna holds a Bachelor of Science degree from Weber State University, and she also holds professional certifications as a certified professional coder and radiology certified coder. She is also an AHIMA-approved ICD-10-CM trainer. And with that, Karna, whenever you're ready, please feel free to go ahead and get started.
Thanks, Trish. I appreciate that. And can I please add my welcome to those that are participating today? I know your time is valuable, and so I hope that we can answer the questions that you have. I do also have a couple of housekeeping things, if I can, before we jump right into the presentation. If you do find that this material would be of value to others within your organization or within your community, don't hesitate to reach out to us, and we'll happily help you assist in preparing an appropriate presentation. This will allow both of us to abide by copyright laws and ensure that the material presented is specific to your needs. Now, while all of the key content within this presentation will be included in the handouts, as Trish mentioned, please be aware that you will not have all of the slides. There may be some that are graphics. There may be some that are live medical records, and I have removed those from the print copy, obviously to help us comply with copyright constraints as well. Now, again, as Trish mentioned, if you have any questions during this presentation, please do not hesitate to use that GoToMeeting dashboard. And then, as time permits, we can respond to those questions at the conclusion of the presentation today. Okay, we essentially have 1 year for that go live of ICD-10. I know that it has been a topic of discussions, well, literally for decades. I mean, I gave my very first ICD-10 presentation in 1989, but it's interesting, I'm still not sure that we're ready for this, and I know that many out there are really hoping for that last-minute stay of execution. Surely someone will realize how difficult this is, have mercy on the providers and the vendors. Not so much. CMS has been very, very vocal that there will be no further extensions. So that said, we really need to be realistic. We need to anticipate that there are going to be a few snags in the go live. So as we think about implementation in this next hour or so, I really want you to think about, here's what I need to do, here's my alternative plan or my contingency plan, and then here's my plan if the payers aren't ready. And we really want to be aware of all of that. So it really is the reason that we're here today. We want to talk about those potential snags. I want to make sure that your individual implementation plan covers the bases. And hear me very clearly, there is no plug and play. There is no off-the-shelf implementation, anything out there. Your implementation plan has to be customized to your organization, to your workflow. This is a concept that's going to be integrated into the whole world. Even within this limited audience, we do have a variety of perspectives. We have a physician who will be in the trenches selecting the I-10 codes because they have to complete their progress note. But we also have managers on the call today who are going to be concerned more about productivities and staffing and training their staff. Well, to the software vendors or the data management staff, then you're going to be hearing what I say today in a slightly different agenda as well, because you're looking at how this new data is going to impact your product and perhaps your data transfer requirements. I know that the coders are starting to grasp the fact that the number of unspecified codes we have now is going to be magnified if the clinical documentation does not dramatically improve within the next 12 months. And I would love to tell you that there's this magic wand and poof, and it fixed. But there is no magic wand for a one-stop implementation, and I need to have you hear very clearly. ICD-10 is not a software update. There is not a software out there that is going to magically fix, upgrade every element of this organizational impact. And it is also not something that the coders are going to own. This is probably the first true team effort that we've had in healthcare in a very, very long time. Now, I appreciate that the software vendors will have the new code set, and it will be available within your system, and you will have the appropriate fields. But that doesn't mean that the processes for utilizing the tool will be magically updated. Ancillary departments are anxiously waiting for better clinical information on the orders or the requisitions. But that's not going to be 100% of what they need. In today's world, we have more information at the treating physician office than we give on a requisition. So just because the treating physician or the ordering physician will have additional information does not mean that the ancillary departments are going to be, in great shape. We still have to talk about the data transfer, and we still have to be very much aware of how it's going to apply. Probably the most important myth I want to debunk here for a second is the very last bullet on the slide, and that is we're just going to use the GEMs. Now the GEMs, and by that we mean the general equivalency mapping, they were designed to be a tool for converting the existing data and the policies for the purpose of trending, for the purpose of offering sort of a starting point for the overwhelming task of revamping all those LCDs. The GEMs have an incredible role to play, but like any tool, it has to be used appropriate. They were not and should not ever be used specifically for coding or claims submission. They have that place, but I want to emphasize the risk in using them exclusively or relying on them to be your implementation plan. Please consider the recent study by the University of Chicago that I'm showing here on the slide. 40% of the translations are complex. 36% of them are convoluted. So right there you're looking at 76% are not as smooth and as simple as perhaps the marketing behind the GEMs would have led you to believe. Can I just share a couple examples of what the GEMs will look like or what the crosswalk will look like? And honestly, these are two very straightforward examples. A single ICD-9 is going to potentially map to multiple ICD-10 codes. So which will be used? Both? Is the payer going to cross a covered to a covered code? Or should we anticipate that some of our covered codes may actually be crosswalked to a non-covered code? ICD-10 is going to actually offer a lot of combination codes. So again, it's going to raise the question about that mapping. When a single ICD-10 code maps back to multiple ICD-9 codes, how is that going to drive reimbursement? Now, it is very important to know about the GEMs. It's very important to have the appropriate stakeholders have access to the files so that if the claims are denied or the claims are challenged, if I need to compare data across service states, well, then this tool is very appropriate. Many payers and many vendors have already completed these type of crosswalks. If you go out to the private payer websites today, you can actually review the medical policy guidelines or the LCDs if it's Medicare. You're going to see the ICD-10 codes. You can begin that analysis of old to new today. Now, CMS nationally has said that they will have their LCDs crosswalked by January 1 of 2014. Despite the amount of work that is going to be involved in this transition, we do welcome the new code set. Our current code set is over 30 years old, and so it no longer supports the needs of data collection or the needs of reimbursement. If you think about the clinical demographics of your patients, if you think about the severity of your patients, but the average insurance claim continues to be limited to 1, maybe 2 diagnosis codes, and those are flooded with the unspecified. So we really do, from a clinical perspective and from a reimbursement perspective, really want to embrace this. The payers are going to continue to focus on medical necessity. So it's imperative that the claim clearly communicate the severity of the illness, the complexity of the patient's presenting problems. We're just about ready to accept that healthcare in the United States is marching towards that pay-for-performance. We're continuing to increase the number of quality measures or the evaluations of the outcome, and it is a pay-for-performance. So even if we weren't dramatically updating the actual code set, many of the implementation steps that we're going to talk about today have immediate value to your organization if you would implement them tomorrow. Reality is that technology is going to continue to drive healthcare. Data mining is the first step to evaluating the accuracy of claims submission. We use the data to evaluate the effectiveness of treatment plans or to evaluate any trends within healthcare. So we need to follow that golden rule, and that is he who has the gold makes the rules, or he who has the data makes the rules. And I can share the personal victories of being able to use data when I negotiated contracts, when I was fighting for carve-outs to existing policies, or when managing limited resources. And if I had the data to say, look at the complexity of our patients, it was a much easier fight. If the physicians and the healthcare organizations continue to underreport the complexity of their patients, payers are going to undervalue the care that's provided. It is a flat cause and effect relationship. Unfortunately, not all stakeholders are going to see the value of this new code set. I know the physicians, the providers are extremely frustrated with the percentage of their time that they perceive is diverted from hands-on patient care and reallocated into administrative tasks. I appreciate that, and there is truth in the complaint that it can take longer to get the treatment plan pre-authorized and paid than it did to actually treat the patient. It's important to completely understand who your customer is as we try to sell this actual implementation of ICD-10. Acknowledge the frustration of the physicians and try to manage that from a clinical perspective, and not so much focus on, well, you have to do this to get paid. Part of that is please don't be distracted by the story codes. Don't allow those in your organization to latch onto the number of codes that can communicate the way a person can be injured by a turkey, or struck by a turtle, or caught on fire while on jet skis in the water. The codes exist, but it would really be unfortunate if we lost the clinical value of this implementation for these few handful of codes that we probably won't use. Reality is we have these story codes now. They're called E-codes. And if you're so inclined, you can report today the fact that someone got sucked into the engine of a jet aircraft while at sea. But we don't. And so as we promote implementing ICD-10 within your organizations, stay focused on the clinical benefits. Stay focused on the expansion of codes that will tell a better story about the cause and effects of conditions and treatment or the complexity of your patients. We can enjoy all of these fun additional codes, yeah, within our team meetings, but try not to focus on those or derail your implementation because of them. One immediate observation while you review the ICD-10 guidelines is the fact that there will be more clinical conditions reported. So we really need to move beyond the focus of this code pays and realize that a single code rarely communicates the complete complex medical scenario. Rarely does a patient have a single complaint Their single complaint of leg pain is really complicated by the underlying hypertension, the history of peripheral vascular disease. And oh, by the way, do you remember that they had a personal history of a TIA 3 months ago? It's that encounter we need to focus on. So CMS can currently accommodate up to 8 diagnosis codes per line of CPT. However, I am aware that internal limitations of our software may not even allow us to do 8 today. So now is a really good time for that conversation with IT or with our vendors to make sure we're expanding those fields. Now, as you hear that, recognize the change that more will have on productivity. And while it obviously takes more time to keystroke 30 characters than it does for 5 digits. So the number of keystrokes is going to increase exponentially. And then there's the reality that an alphanumeric pattern is more time-consuming than a straight numeric combination. So try to anticipate those impacts of the ICD-10 implementation as well. This is not just a code set. This isn't just translate 401.9 to I-10 and we're home free. I think that the best approach to this complicated project is straightforward and honest. There are days when we will be herding cats. Simply recognize that not everyone will embrace the change with the same level of enthusiasm. So I'd like you to find those 1 or 2 within your group that are perhaps a little more curious and a little more willing to be the champion. Start there. Another scenario to consider, or an application of this slide. Unfortunately, organizations are fielding a number of requests for retirement from key veteran staff members, staff coders. I am very disheartened by the number of physicians who have decided that they will retire before the implementation of ICD-10. Wow. Can we really afford to lose that knowledge? The knowledge of your organization, the relationships of the providers, the process, just because of this implementation. Can you think about the reality that someone is going to need to manage the ICD-9 carryover for well into 2015? Do you have the capacity within your functions to sort work queues by service date? If you can, then please direct all of that pre-October of 2014 to this specific team. Allow them the comfort of continuing to work in ICD-9. And then once all that dust settles and they can see that, yeah, I can adapt, perhaps some of them will remain employed, and we need that. Finding qualified staff is a challenge now, and that's with every organization in your geographical area vying for the same qualified resources. ICD-10 is just going to tighten that playing field. So there are 3 primary areas within any organization that are going to see a significant impact from the conversion of I-10. It is going to impact the operational workflow, your productivity, your vendors, etc. It's obviously going to impact your reimbursement. And then you can see which I'm putting the highest emphasis on, and that is your provider documentation. But we still have a limited number of resources, and so I'd like to sort of walk through these and talk about how we're going to implement ICD-10. It really does not matter if the software has been handcrafted and the CFO managing an unlimited credit line. If the physician documentation is incomplete, that charge capture process is going to come to a complete halt. It really isn't about being paid less. It's the claims can't leave the building. So we know that, but can I offer one example of a challenge we have today? This slide offers a very simple example of the data transfer challenges. Currently, as Coding Strategies performs these I-10 readiness audits, we find an uncomfortable amount of encounters where the data that was available on the order, that bottom block on your screen, the data had details. It said lower lobe lung. But when that data got carried forward onto the actual radiology report under the clinical histories or the reason for the visit, you can see what dropped off. We need to improve that data transfer today so that we don't have the ordering and the primary care physicians diligently, providing the level of specificity, but somehow in whether it's a human transfer, whether it's a systematic transfer, We've got to be very careful that all of the data available is transferred to the appropriate players. This is going to be a significant roadblock to successfully implementing ICD-10. Now, the documentation, whether it's the office visit or whether it's the actual, CT images of the chest, abdomen, and pelvis, each record is going to need to completely communicate the laterality, the specific site. Give me the complete story. Yes, this patient is probably being treated for active breast cancer, but if the focus of the evaluation was on the pleural effusion, perhaps there were also additional signs and symptoms, whether it's shortness of breath or chest pain or an abnormal study, etc. I have a feeling that there's more information that would directly explain the clinical necessity for this CT of the chest and abdomen. When you consider oncology, just again as one example, too many times the primary diagnosis remains breast cancer or remains the specific neoplasm. It doesn't include the nausea, the vomiting, the dehydration, and everything else that was managed during that encounter. It doesn't even really communicate that the primary conditions managed during that visit were actually not the neoplasm. So I want to respect that the provider has the expertise in the practice of medicine, but very few were taught the nuances of documentation when they completed med school. A lot of the residents just followed in the footsteps of their attendings. They either created templates based on their attendings or they used their attendings templates. Those might be outdated. Can I encourage you to be conscious of your communication? Very few people, and especially not providers, like to be approached with, "You didn't. You didn't document." Well, in fact, "you didn't document" may be very misleading, because unless you were present in the room for that office visit, you don't know what was done. It isn't a matter of not documenting. Let's go to the other side of it and say it's not that they didn't document spectral analysis. They didn't do it. It's not that they didn't document the patient's immunization record. It wasn't reviewed. So now really is a good time to improve the communication between the clinical and non-clinical staff. Ensure that we're really learning from each other the best process to accurately capture the care that's been provided. Now, the EMR has successfully exploded the average medical record into a 3-trilogy saga. I get that. So I don't want you to add to that. Excuse me. It really isn't about more. It's about the specific clinical facts. If the fact that the patient with abdominal pain is status post-gastric bypass, yeah, I need to know that. If the fact that the patient's shortness of breath needs to be monitored carefully because they are, they have COPD or they have asthma, then that's what we need to include. Recognize that the specific details really can be categorized, into 4 or 5 categories. If we're looking at the laterality, if we're looking at the specificity, the specific site, whether it is the quadrant or whether it's the distal or proximal or waist of the navicular bone. We want to consider the clinical relevance, whether it's acute, whether it's chronic, whether it's with or without obstruction. Does the fact that the patient is an uncontrolled diabetic assist in communicating the complexity of the case? What about when the diagnostic imaging is suboptimal because of the patient's body habits? Those details need to be included within the assessment plan, within the order, within the requisition, and then it will be communicated on the billing form. So can I just share a quick example or two of the type of details that are going to be available within the ICD-10 code set? Can you also use this slide as an example of the type of analysis that is needed within your organization? As you decide exactly how ICD-10 will impact your specific scope of practice, follow this example. Take the top, 25, 30 categories in ICD-9, and by category, look at this slide. 812 is the category. It's just the generic 3-digit code. Now, match that category up to the category in ICD-10. What are the new decision points? In other words, what are the details that are going to be necessary to choose the S42.32 versus the S43.35. What makes one code unique from the next? That, my friend, is what is going to need to be documented or captured or transferred from that ED note to the radiology order to the specialist, the orthopedist that you sent them to. So I would encourage you to review the types of documentation. Let me quickly jump over here if I can. How you present the information needs to be unique to your organization, and this is just another way to say the same thing. CSI has been working on these documentation guides so that you can go through and say, first that it's right or left, and then is it a tear, is it a sprain, and what's the specific location for that. Notice towards the bottom that we're going to have to document the episode of care for all injuries. So is this the initial, is this a subsequent, or is this a sequela? So this kind of a format may be very useful to you as you proceed. We talked about combination codes that will be available within ICD-10. And if we look at atherosclerosis as just one example, if the patient has rest pain and claudication, there's going to be a single code. When we move to the right-hand side of the screen when we're talking about gangrene, then the code is going to include the fact that the patient has rest pain, claudication, and even an ulceration. Documenting the underlying cause of the condition when it's appropriate. Is the fracture a result of a traumatic or a non-traumatic event? Pathological fractures may be the result of osteoporosis, but they are also the consequences of other disease processes or other treatments. Within the current code set, I know we have a lot of instructions that say code first, code underlying disease. Well, we're going to have more of those as we move into ICD-10. So as you think about most of the neoplasms, they're going to require some part of social history. How does that impact your focus? If you're the treating physician, is the fact that the patient is, personal history of nicotine, is that data carried forward visit over visit, or are you capturing it only on the initial encounter? If you're considering the reasons why we need more than 4 diagnosis codes per CPT code, this is just a very quick example of why. So those on the call today that have that focus of IT or that focus of the systems piece, you need to be aware of this type of explosion. If we're trying to update a clinical physician order entry system for ICD-10 implementation, is there an opportunity to link this data field from an electronic field in the progress note to the appropriate field on the order entry? Because a lot of things are going to be the underlying history. They're going to be the fact that the patient was treated with radiation or the fact that the patient has post-chemotherapy. Another change that is going to impact the number of codes, the way we code, the way we gather data, is with our pregnant patients. ICD-10 is going to consider the pregnancy state of a patient to essentially trump all other conditions. So even this x-ray of the shoulder that's just pain, the claim will report the patient's second trimester pregnancy primary. Then I will get into the fact that there was a dislocation, the number of weeks, and the fact that it happened while she was playing baseball. Now, this is a paradigm shift for most claims processing systems. Currently, we've worried about the primary code because that's the only thing that was used to be paid. Moving forward, I encourage you to closely monitor the claims processing so that the primary code doesn't automatically deny it. Pregnancy and a shoulder x-ray traditionally would not support each other. So as you're testing the software with your vendors, don't test the easy stuff. Test the cases like this that are going to challenge what we have historically done within the healthcare industry. Now, within ICD-10, an office visit by an oncologist for a patient with post-treatment for breast cancer, this is what it will look like in ICD-10. Yes, I am willing to bet that very, very few claims are this detailed. And you can just start thinking about data, how's this going to be impacted? From the physicians, how is that going to be impacted? The coders, all the way down. But I do want you to keep it clinical. You know, I've already suggested that you stop short of coding all of the 9 codes for an assault by a turkey. But ICD-10 guidelines also say that we're coding to a specific room of the residence, and a single-family residence versus a dormitory versus an apartment. Please check with your local payers. Remember, this is a golden rule. Very few are going to require this level of detail. We're seeing the additional details really fall into 3 buckets, and so here's 3 questions I would like you to think about asking. Number 1, do the secondary codes add to the complexity of the patient's presenting care? In other words, status post-gastric bypass, family history of cancer, personal history of cancer. If the code adds to the complexity, report it. Second question, are the details necessary by coding guidelines? In other words, if I have to code their alcohol and tobacco use in order to report cancer, well, then you're going to code them. And then the final thing is, think about if it determines the responsibility. If there is an ICD-10 code that communicates the accident was a car accident, or if it was at work, or if it was a school activity, include it. And that may actually help some of the processing. Please avoid the temptation to code every single event code unless we're directed to do so by the payer. There is going to be enough work out there just to meet the minimum requirements of this new code set. So let me sort of bring this home for you. Regardless of your individual perspective, whether you're the coder, the physician, the manager, vendor, think about your objective for participating today. What we want to do is be able to establish the medical necessity for the care that we're billing through describing that severity of the condition. So if you're personally providing, you're personally generating that medical record, assist with the technology to capture this level of detail. If you're managing the data after it's been captured, how will this impact your job, October of 2014? What are you going to need to be able to do your job? And what is the most efficient manner to get those resources? And again, please do not assume that your software vendor has it covered. And I have, complete respect for them. That is not said in a derogatory manner. But respect that everyone is venturing into uncharted territory, and we're all going to have to sort of check each other's back when it comes to testing this new programming logic. Sometimes the programmers do not have the extensive background in coding. Sometimes they are answering the request, or they are being pressured by the physicians so that there's only 3 clicks or 2 clicks. This is a live record, and those on the call who have a little bit of coding background will immediately see the challenge. This vendor requires that the assessment be linked to an ICD code, and obviously these are ICD-9 codes. But pressure of the physician and design of the vendor has created an inaccurate situation. If you look at the second line item, rule out type 2 diabetes, okay? The physician said rule out. But that terminology doesn't exist in a diagnosis code set, so it was assigned to 50.00, which we all know is the confirmed diabetes. Same thing happened with the migraine headache. Even though it was possible, the vendor, the software, the process forced it into a confirmed code. So we want to make sure that we're testing any upgrades that we have for I-9, that we're not replicating problems from test I-10 so we're not replicating problems from I-9. I know that the technology can include the diagnosis code as part of the assessment, and for some vendors, we can pull forward everything that we have. Okay? Just because I can doesn't mean that I should. If the data service is July 11 of 2011, do I really need the December of 2010 diagnosis code moving forward? Think about your active medical history. Think about every aspect of your medical record that is currently using diagnosis codes, and how will and who and when are these getting crossed to I-10. We're so driven by the code data sets and so driven by point click. I know, they don't want a free text, I got that. But the challenge is, from a patient treatment, this medical record is a tool for the next patient's care, How helpful is it to know that they were screened for a condition not otherwise classified? Okay, that really doesn't help anyone. It doesn't help me as the patient 6 months from now when a new provider follows up, and it doesn't help me support the medical necessity of the claim. So the technology can assist, but it doesn't mean it should. The AHA Coding Clinic, the American Hospital Coding Clinic, has been saying now for almost a full year and a half, it is not appropriate to list the code in place of a written diagnostic statement. And so we don't want to lose the primary objective of a medical record being a communication tool. ICD-10, I'm sure you're sort of getting the sense that this implementation is a great opportunity to evaluate the entire operational workflow as a whole. Identify all of the areas within your organization. What are the requirements? Can you place an order without a code? Can I free tax? Can I bypass a field? Really think about everywhere within the organization. And I know we are a paperless environment, except where we're not. We still have a substantial number of paper records, whether it is the daily hospital notes, whether it is the requisitions, and this is obviously a paper rec that's shown here. Patient questionnaire forms, the review of systems that they fill out, that ROS. We need to ensure that we're taking into consideration all of the type of data collected on paper, because if we scan it, okay, it's permanent, but it really doesn't help with the data transfer. So then there has to be a human being who's taking the data from that scanned copy and moving it forward. Well, if the information on the patient intake form contains that social history necessary or the past treatment history that's necessary, how are we going to change that step in the next 12 months? Okay, I'm going to trust that I have sufficiently highlighted the types of changes that are going to need to happen. So let's switch gears just a little bit. And I want to look at the steps that you can take to ensure that you've looked at every level, every nook and cranny, and that you've updated everything that's necessary. I am still going to focus sort of on the documentation, because it doesn't matter whether you're looking from a software perspective or a financial perspective. If you listen with, okay, how does this affect me, mindset, if the documentation doesn't improve, well, then we're going to see a drop and change in denials. Charges submitted in October are projected to be paid January, late February. Is the organization positioned to handle those kinds of receipts? So that's sort of what we need to start looking at. We want to be able to identify these current documentation gaps. We want to identify where those gaps might be coming from, and then I want to find the best way to use the resources. Essentially, you know, it all comes down to just start where you are. Use the data that you currently have to establish an implementation plan that is unique to your organization. So what does that mean? Give it to me in English. Currently, I bet everyone listening is familiar with the frequency report for CPT codes. Okay, switch gears just a little bit. I need you to create a frequency report that is diagnosis driven. Within your organization, that might be a quarterly or that might be a 6-month. You know, make it a reasonable, a manageable size of amount. If there are seasonal considerations based on your geographic or your practice mix, then obviously you want to pay attention to that. But I'm going to end up with this massive Excel spreadsheet. And I'm going to go through and I'm going to be looking for a significant volume of anything that ends in a 0.8 or that ends sort of in that 0.9. So here's just a quick data dump, for lack of a better word. And here's, you know, let's pretend that this is our list of diagnosis codes we've submitted in the last period of time. So the next thing I'm going to do is very quickly go through and I'm going to find my 0.9s. Then I'm going to see what the record was. Was it incomplete because the coder just put on a 0.9, or did the data not exist? You'll notice between the two top circles, there's a 553.9 for a hernia. Not every 0.9 code is bad. Sometimes that really is the only ICD-9 code that exists. So it's going to take a little bit of data mining to really drill down to the valuable information. But step 2, once I've got those 5 or 6 or 10, 0.9 codes that I want to evaluate, then I want to randomly collect, just maybe 10 records for each of those categories. And remember, a category is the first 3 digits. So I want to look for trends within that specific category. Are they coming from a specific provider, from a specific location? Is it inpatient? Is it outpatient? This is really more than an audit. This is an assessment, being able to determine the source of the problem. We're really going to isolate the reasons for those NOS, or not otherwise specified, and not otherwise classified. Is the root cause the documentation? Is the root cause the coding? Is the root cause a workflow process, like we saw on that lung cancer as we went through? Try to really focus on not only where the data comes from, but who's going to use it after it's been entered by any one of these various systems. And by this, are you involved in any clinical trials? Think about that. Does anyone within your organization data mine diagnosis codes for the sake of marketing? In other words, you're looking at the types of patients sent to you from, physician A versus physician B. We really want to get a handle on everywhere that this kind of data is used, and then we can evaluate it appropriately. This is a statement from a HEMA, and I really think that it is our key to being able to handle this transition efficiently. Proper documentation can be facilitated through the effective use of the electronic health record, through templates and through prompts. Data that is repurposed. In other words, can we collect it once with that initial visit or that primary care visit or that consultation, and then have it appropriately available for the rest of the provider care team, whether it becomes the follow-up visits, the subsequent visits, etc. I think the most dangerous response when we're discussing workflow process is they add the codes. They enter that information. Who is they? Be really specific and ensure that every person that you have under that category of they is included in the appropriate ICD-10 training. Just last week I was working with a group on an operational assessment, and we had IT and the physician champions and the nursing. We have all the appropriate players around the table. And we talked about, okay, where does this field come from? Everyone around the table pointed at somebody else. Well, IT should get that to us. Well, the nursing staff should get that. Well, coders should be able to get that. These vague, they do it, is going to derail our ICD-10 implementations. Too often I really hear that the coders will do it. Really? Be sure that we're speaking about the task of coding, which really is a majority of the people, and not just a job title. Look at the screen. These job titles frequently perform the task of coding. And so if you will focus on the task and not the title, you'll have a more successful implementation because you'll make sure that the appropriate people are trained. And that does include IT. There's a lot of times where they will drive actions based on the diagnosis code, whether it is a red light, green light, yellow light for an order, whether it is data that's going to be sent to a pre-authorization, pre-registration team. I'm hoping that you're really starting to get a sense of just how penetrating this implementation is going to be. Now, our experience is that you can really address 80% of the conditions on a short list. So it's not a matter of tackling every single code in the book. Once you've got that list of your gaps, then prioritize them. And I'd encourage you to prioritize them based on two things: clinical significance and the degree of change within ICD-10. And notice that I have clinical significance first because that speaks to the physicians. That allows them to stay focused on the patient care. And not all clinical conditions are going to require additional specificity in ICD-10. In some situations, we've got 3 ICD-9 codes dropping into a single I-10. Conditions like multiple sclerosis or Parkinson's, they are going to be as straightforward in ICD-10 as they were or are in ICD-9. And so not every code is going to need the same level of scrutiny or the same level of training. So once you have your codes on this short list and you determine that they're going to need a special, additional specificity, sort of categorize those decision points. Categorize that all of your injuries are going to need location, laterality, and episode. Categorize that these specific conditions, think diabetes, think kidney disease, end-stage renal, we may need the underlying disease. If I draw again on diabetes, then I'm going to need to know the long-term insulin use. And obviously there's long-term steroid use and other things that are going to factor into that. But if you can sort of create the buckets of additional information. Now, I've already shown you one slide as a way to present those additional details, but really consider a variety of ways in which you can share these specificity requirements within your organization. We have a lot of different dictation aids now on the CPT side. Now think about it. When you are thinking CPT procedure codes, we currently have templates or checklists so that the physicians don't forget all of the elements of an HPI. Or on the diagnostic side, they don't forget all the components of a comprehensive abdominal ultrasound. The physicians are used to those kinds of aids. We just have to come up with the same kind of template on the diagnosis or on that clinical history side of the report. So if you look at the diabetes that I have here on the screen as an example, if we're going to talk about diabetes, then I need the type. I need to know if this is primary, secondary, or if it's gestational. I'm going to need to know the cause, if there's any complications, and the severity of that. If we look at peripheral vascular disease, well, I'm going to need to know if it's a native vessel or a graft, the location, the severity, the laterality. If you take your top 25 conditions, categories, compare old to new, you're going to see a pattern. You're going to see that the lion's share of your conditions fit into those types of buckets, because at the end of the day, I just really need to consider that I'm communicating the clinical complexity to the payer. I'm really trying to capture enough details that are going to be pertinent from a clinical, whether it's research, whether it's trending, cause and effects, any data analysis perspective. I really want to capture the complexity of it. So really watch for the details. What's the source of the underlying infection? What's the details of that original fracture? When you're seeing the patient status post-fracture care 2-3 weeks, you're doing cast checks, you're doing suture removals, whatever the scope of your care is, the same kind of details are going to be necessary. Now, beyond the original data mining that you can do from, obviously, frequency lists, you may have some additional resources within your arsenal, depending on your perspective. Don't hesitate to look at ordering and admitting signs and symptoms. Engage your coders. I can promise you they know which physicians they have to go data mining and dig for additional information in order to assign the ICD-9 codes today. If we struggle to get an accurate ICD-9 code today, yeah, we're going to struggle in I-10. So use your coders, use your billing people, and as you manage, you look at the denials for medical necessity. You can data mine for that code, your C50, your CO50. So try to get a trend and try to get a handle on where those are coming from. The medical necessity reviews, we still want to prioritize them. You can't spend 80% of your resources on 20%. We got to flip that. So identify the payer, the physician, or the location with the highest volume. And then again, still look at it from an analysis perspective. Was it because of insufficient documentation or an unspecific diagnosis code? If we put time into this analysis up front, it'll save us time when it comes to educating or it comes to actually putting together that target plan for our education. Now I know that there's a lot of information, and I think the other piece we can't forget is that we need to accept that ICD-10 is not like any other project. There is a go-live date, October 1st of 2014, but we will be forever evaluating the gaps, analyzing the information, looking for opportunities to more accurately capture the data forever. So we need to plan for the staff and the ongoing training to ensure that this piece of the organization and this process remains really fluid. Now, most organizations right now routinely audit for compliance. Unfortunately, most of those audits are currently focused on the accuracy of the CPT code. In other words, does the documentation support what was built? Now is the time we need to sort of shift that focus. We need to audit for the accuracy and the completeness of why. Why was the office visit provided? Why was the surgery done? Hospitals have stepped into that, patient safety measures, report the quality of measures. Hospitals have been doing this for quite a while. ICD-10's implementation is really going to drive the physicians to follow that same kind of pattern and that same kind of attention. So let's take this really in steps. Yeah, I know. Even in a webinar, I can see some wide eyes and know you're probably looking for yet another piece of paper to take notes. So really be kind to yourself and patient with others. I think a phrase we have in our office is grace and forgiveness, because this is a huge project. Take it one bite at a time. We're going to discuss a specific number of clinical conditions. So if we've got 12 months until we go live, then let's slice and dice that so we're looking at a specific clinical condition or two each month, and that is across the organization. So we're looking at it from scheduling, from pre-auth, from history intake, every aspect of it. Let's just focus on those one or two as we go through. We're going to anticipate the coders want to practice this new skill set. Because if I learn something and then I don't use it, it's that lose it or use it. But we have to make sure that we have our steps in appropriate sequence. We really can't ask the coders to use their new skill until the documentation is clean. And I really can't expect the documentation to be better until the electronic record has the appropriate fields or the necessary fields or the free text options to be able to capture that amount of detail. Just always remember you're the face of ICD-10, and we've all managed change. We've all managed enough implementation projects, enough lean projects. We really know that if we can get behind it, believe in it, and be excited about it, it's a lot easier to engage our teams. If we are resistant to it, if we're frustrated by it, if we verbally say that this is the stupidest thing that's ever happened, it's going to be a lot harder to get buy-in from the team. And as you saw from the earlier slides, the physicians are already a little resistant. So what we really want to do is put a face on it of how this will improve the clinical. I agree. It's going to take some additional time. It may continue to have the physicians focused on the chart and not perhaps the face-to-face to the patient. So how in the long run can we help that happen? So here's the question you're waiting for. How are you going to get this done before October of 2014? We're going to get it done just like we do everything else, one step at a time. For some of you, you are well into the implementation process, and you're participating today just for some reassurance that you've covered all the bases. You know, you've thought about those human resource questions about, oh, I really don't want all my coders out of the office fourth quarter of 14, but we've got to use it or lose it vacation policy. You know, you've already thought all of those things. For some of you on the call, you're finally coming to terms with the fact that this is going to happen, and so now you're going to start dedicating resources. So where are you? Have you selected a provider champion? It's a lot easier to make documentation changes. Some of those are better peer-to-peer. And so if you've got the champion, allow them to help you assess the documentation disconnects. We should have a good understanding of the best way to train our clinical staff. Is that in little podcasts, you know, 3 to 5 minute segments that are available on their iPads, on their smartphones that they can listen to while they drive to work. You know, we all know that it is not, the training method for physicians is not to put all of them in a room for 8 hours in a boot camp environment of coding. That's not going to happen. So what is the best way to train? Hopefully you can draw upon that knowledge from other projects that you have been on. What we need to be doing right now is all clinical support staff, and by that I mean anyone who's touching, creating, reviewing, or impacting the medical record. They should be the priority for learning ICD-10 coding. I have found that if my nursing team, if my clinical support staff, whether it's the technicians, the nurses, etc., if they understand the new code set, and then I train my physicians, the physicians go back in the clinic setting, and they may be grousing a little bit, or they may have questions. But as if they ask questions or if they grouse and the nurse says, oh yeah, we got trained on that, and here's how to work with it. Here's how it'll work in our office. Then that can reduce some of the stress immediately. Today or now, we want to be prioritizing the clinical conditions so that we're not trying to eat the whole elephant at one time. We want to determine which codes are going to be spotlighted within which months within our organization. Once we've got that done, then it's this circular method. Continue to provide feedback, continue to look at the records, provide new training information. I want you to really think about how you provide information within your organization. Every one of us that watches TV has a remote control and a mute button. And after a while, when you've seen the same commercial over and over and over, you just hit the mute button. Now, training's the same way. And if we've got 12 months that we need to focus on training ICD-10, then we really need to think of ways to mix it up. Like I said, whether it's podcasts, whether it's face-to-face training, whether it's a grand rounds organizational wide, you've got to think of new ways for training information. Does your organization have the technology so that when I sign on to my computer and start my work day, do I get a welcome message? Some organizations, and I'm thinking a lot of hospitals, they have a little thought for the day, or HR might have a reminder that the flu shots are available. Okay, if you have that capability, is there a way to leverage it? In other words, I gave my IT guys once when I was working as a manager, I gave them all my coders job classification. So this user ID was in this bucket. And so for a period of time, any coder who logged onto the system got the normal hospital message, organizational message, but they also got a coding tip of the day. And there was a specific agenda for it, but I've thought about, you know what, I could use that in implementing I-10 so that there is a guideline that comes across every morning, or there is a, interesting coding tip. Some of them have actually gone into creating scavenger hunts for going and finding the most specific code, the guidelines for sequencing a specific complex case. We've got all the tools and the resources. We've got the codes. We've got the guidelines. Everyone is sort of aware of and interested in I-10. It's just how are we going to mix it up? Now, when I say future, we're talking about July, August, and September. Right now, today, is not the time to be discussing the minute details of Code 1 versus Code 2. We're not implementing it today, and so we really still want to stay categories. We want to say laterality versus severity, but those last 3 months before go live, we really want to drill down into the details of sequencing codes. We want to drill down to the fact that this Blue Cross Blue Shield plan is not ready, so we're still going to give them I-9, or this indemnity plan is never going to transfer. Bring out those details once you've got a solid foundation of everything else. Those last 3 months is when we're going to start auditing for I-10 as aggressively as we currently audit I-9, and then we make sure that we're not missing anything. This is an adventure, and it says, when life brings the big winds of change, just close your eyes, hang on tight, and believe. And if I can add one more piece to that, and that is, please do not reinvent the wheel. And I'm offering some products and services that CSI has, but we are definitely not the only resource, and you need to go to the authoritative sources as well. Make sure that all members of your coding team and key players on your clinical team have access to the AHA Coding Clinic. That is that quarterly newsletter from the American Hospital Association. Starting, a year ago, they were putting Q&As in every quarterly newsletter related to the application of ICD-10. So that is a resource from an authoritative source that you really want to make sure you've got your hands on. If your team learns best face-to-face, then make sure that they are in opportunities where they can network with other organizations when we're on a managerial level, so that you can learn from other organizations of your size and that have your perhaps payer nuances. Obviously, there's a lot of online training that's out there, both for coders, both for physicians, and both from an implementation team. So just explore. Recognize that not everyone is going to need the same training, not only from ICD-10, but how long has it been since your coders have taken anatomy and physiology? Are there ways we can leverage the nursing staff within our organization to provide some of that overview and refreshing courses? Is it best if we do web-based so that it can be more along the lines of the coders? Reference guides are out there. Like I said, there are implementation toolkits that are available by specialties. You simply do not want to reinvent the wheel as we embark on this wonderful adventure. Trish, if I can bring you back into the equation and see what kinds of questions that have been raised, if any, and I'll be happy to try and address those.
Absolutely. Thank you, Karna, for a great presentation. And several people have asked whether or not we will be providing the slides as handouts. And yes, everybody on the line will receive a copy of the slides, the handouts today, as well as an audio playback option, so you can listen and pause and take notes as you need to and at your leisure. You sort of touched on this earlier, Karna, but one question that came in is, do you have a list of qualified people and organizations to train our providers? And like I said, I know you touched on that briefly, but if you have any other resources that folks might be needing to be aware of, if you want to touch on that for a second.
I would be happy to. And when you're looking at training, I want you to look at two things. I want you to, number one, make sure that the training is, for lack of a better word, approved by the authoritative sources. And so that's coming from the AHA, and that's coming from a HEMA. But then can I add one extra little qualifier, and that is not all specialties are created equal. And so I know that if I am, let's say I am a pediatric physician and I want ICD-10, I really don't want to go somewhere that's going to have a third of the day on nursing home or skilled nursing facilities. So as best you can, find training that, number one, is approved, trainers that are approved by the authoritating bodies, but two, you want it customized to your specialty. Now, obviously, primary care, you get to learn everything. But, you know, when we train in radiology or we train in cardiology, then obviously we're going to spend less time on, say, ophthalmology codes, or we're going to spend less time on fracture care if I'm talking to a cardiologist. We have limited resources. We have limited time. And I want to make sure that 100% of that time and resources addresses my needs. If your organization and your group is in a position to, it is almost always cost-effective, more cost-effective to bring the training on site. Now, for your managerial staff, I find value in the networking, for them going somewhere. But for the frontline coders, for your physicians, if you can bring that training on site, do it, because then they can train from your documentation. If I go on site, then I don't have to worry about HIPAA. And I can actually put up your impression and plan. I can talk about your workflow. We can have, you know, someone from IT available to answer questions. And public training sessions don't always allow for that. So really look at their credentials, the specialty, and your primary objective.
Great, thank you. And actually, that was the only other question that we had come in. So on behalf of CSI and Orion Health Corp, we'd like to thank you again for attending today's webinar. And like I said earlier, you will be receiving a copy of the slides as well as an audio playback option. And once again, Karna, thank you for your time and your expertise. And we look forward to seeing you at a future webinar.
Great. Have a great day, guys.